So now let's talk about systematic reviews and meta-analysis. The first thing is what is a systematic review? A systematic review is a review that is conducted according to clearly stated scientific research methods and is designed to minimize biases and errors inherent to traditional narrative reviews. So essentially, the important point in a systematic review is to have a well-defined method to minimize biases. Why are systematic reviews important? Every day there are 1,000 papers on a specific topic. So for a clinician it's quite difficult to be updated about all the papers on a specific topic. Actually, systematic reviews summarize all the evidence about a topic. And it's not done as in narrative reviews that are performed without a clearly stated method. So there could be an inclusion bias for a paper to be reported in a narrative review. But since there is a well-specified method, it should be an unbiased report of all the available evidence about one topic. So systematic reviews minimize bias. And systematic reviews is a more scientific method of summarizing literature because specific protocols are used to determine which studies will be included in the review as compared with a narrative review. So let's see which are the characteristics of a systematic review. There are two possible approaches. One is mainly qualitative, and then we can integrate a qualitative approach together with statistical analysis, meaning an analytical approach. But this is not always possible, so it's important to understand why it's possible to go from a systematic review to a meta-analysis. That are two different things. So the first important thing is, as in all kinds of studies, is the hypothesis, and this study, also meta-analysis. In meta-analysis, hypothesis must be conceived a priori. This is a very important point. Then there are 4 steps in order to run a systematic review or a meta-analysis. The first step is to identify the studies to be included in the systematic review or meta-analysis, so to identify the appropriate literature. Then it's necessary to determine the eligibility of a study to be included in the systematic review or in the meta-analysis. So a priori we should define the inclusion and the exclusion criteria. This is how in a randomized clinical trial or in an observational study. Then it's necessary to abstract data from the studies that we have selected for our systematic review or meta-analysis. And then, just if it's possible, we can perform statistical analysis. The literature search seems to be the easiest thing to do, but actually it's the most important, the most difficult, because the literature search has to be comprehensive and reproducible. And this is the real foundation of a systematic review. So if the literature search is failing, it means that all the study will be really bad quality. So this is a good strategy to perform a literature search. First of all, this strategy has to be defined a priori. Then we have to decide which databases should be used for the literature search. And it's not just necessary to use PubMed, it's necessary to use several databases, because actually one study could be reported on one database but not on another one. So for example, these are the most used: PubMed, Embase, Cochrane Review, Easy Web of Science, and Scopus. Then we can use also other kind of sources. For example, trial registries. There is clinicaltrial.gov. This is really important because sometimes trials or other types of in this case trials, have results, but these results have not been yet published, but they are present on clinicaltrial.gov, so we can use it to get data about new trials. Data can also be extracted by abstracts from meetings, from personal references, And it's really important to check if there are already systematic reviews or meta-analysis on the topic we are investigating on, because we can use the literature that is already reported on these types of study. Then we can contact the experts to ask suggestion about the literature about the field, and we can also use Scholar, Google, and whatever it is. There could be several biases in performing the literature search for a systematic review meta-analysis. The English language bias is one of the most recurrent. Actually, if a paper is published in English, it's more likely to be included because people can not really speak all the languages. So if a paper is reported on, on a journal in a local languages, and I don't know that language, I could not include that kind of paper just because I don't know the language. There could be a citation bias. It means that study with significant or positive results are more likely to be included in the meta-analysis because they are more likely to be referenced and thus to be identified. And then we can have a publication bias, meaning that studies with positive results are more likely to be published. So data collection is another important point when we perform a systematic review meta-analysis. First of all, it's really important to define which variables are of interest and thus they should be extracted. And this should be decided a priori. So all the investigators can extract from different paper the same variables. So a data extraction form should be used so that the same data are extracted from each study and by all the reviewers. It's important that at least 2 independent readers should perform the literature search and the data extraction in order to be reproducible and accurate. If 2 reviewers disagree, they can find an agreement or they can ask a third person a suggestion about including or not including what study. What do we extract from a study when we decide to include it in a meta-analysis or in a systematic review? First of all, the study characteristics, meaning that we extract the year and the journal of publication, the number of patients in each arm, the treatment performed, and the duration of follow-up. It's also important to extract demographics characteristics like age, gender, males, gender, percentage of males and females, and whatever. This is really important because these variables could be confounders. So if we collect that, we can try to adjust the analysis. We can extract link characteristics. If, for example, if we are running a systematic review and meta-analysis on a cardiovascular topic, we could extract the percentage of patients with cardiovascular risk factors from each study. And then it's important to extract the information about the outcomes that we define a priori, meaning, for example, for a cardiovascular research, all cause death, cardiovascular death, myocardial infarction, stroke, I don't know, new onset of heart failure, and this kind of stuff. Then it's really important the quality assessment of the studies that we are including in the systematic review and the meta-analysis, because the validity of a systematic review depends on the scientific method of the retrieved study and the reporting of data, meaning that if we are including in our systematic review or meta-analysis studies with really poor quality of data, our meta-analysis will be really poor. So there is a way to evaluate the quality of the studies we are including in our systematic review meta-analysis. There are several ways. One of these is the grade. That's a flow chart, and we give a score to each study according these points. And at the end, we will be able to understand if we included good or bad studies in our meta-analysis according the total score of each study. So, as I was saying, it's not always possible to perform a meta-analysis. We start with the systematic review, and then we have to consider if we can perform a meta-analysis. So we can perform a meta-analysis when we are selecting studies that are not too much different in outcome definition. For example, if we enroll if we select trials on, I don't know, on a cardiovascular topic, maybe we are interested to the primary outcome of the trials we are going to include, but the definition of the primary outcome can be different in different studies, mainly because often the primary outcome is a composite outcome, and the composite outcome can be calculated in different way in different trials. So it's important that if we are using the primary outcome for the meta-analysis, all the primary outcome of all the trials are calculated in the same way. It's important to consider the population sizes, because it's true if we have 100 studies, for example, but each study is included in 100 patients, and there is one trial with 50,000 patients, it's obvious that most of the weight of in the estimate of the effect of the drug, for example, will be determined by the hugest, actually, trial. Then it's important to be clear about the population characteristics of the trials we are selecting. Because if we are putting together studies in which just diabetics are enrolled, together with studies in which just hypertensive patients are enrolled, maybe these two populations can be too much different, and it's impossible to put them together. There will be too much heterogeneity. And it's also important to determine if the interventions used in these studies are too much different. So altogether, this means that there should not be too much heterogeneity among the studies we are going to include in the systematic review or meta-analysis. So what is a meta-analysis? Meta-analysis is a quantitative approach for systematically combining results of previous research to arrive at conclusions about the body of research. There are protocols in order to perform meta-analysis. The most known and is actually the PRISMA, that provides a proper procedure for conducting a meta-analysis and to standardize the method of reporting a meta-analysis. So if two people are performing a meta-analysis on the same topic at the same time, they should get the same results because they should use the same protocol that's reported in the PRISMA guidelines. So this is the PRISMA checklist. It's really useful because it describes all the important things that should be reported in the study, in the paper. Actually, it's really important what to report in the methods, for example, and to be precise about how the search was performed, information about study selection, data collection, and assessment of biases, and the statistical methods used, actually. And it reports also important information about how to report the results in order to be precise and not to report biased observation. There are different types of meta-analysis, actually. The most frequent that we read are conducted according the aggregated data approach, meaning that the investigator don't really have the data of the trials, meaning all the data of all the patients, but they just have the papers, so they know the percentage of patients with hypertension in one trial, but they don't have the individual patient data. There are two approaches for aggregated data meta-analysis that are mainly the Frequentist approach, that's the easiest and the most used, and the Bayesian approach. Then there are also the network meta-analysis. And then there is another type of meta-analysis, that the individual patient data meta-analysis. Let's see what it means. This is the Frequentist approach. It's really easy. It means that we select, for example, 10 trials, we use a statistical approach, and we get a result. But if we consider the Bayesian approach, it's a little bit different, because we select, for example, 10 trials, but then before getting a result, meaning like a result got pooling all the studies together, we can include also a priori observations. For example, we can include in our estimation also, I don't know, historical observations, or if we are doing a meta-analysis of randomized clinical trial and we are following a Bayesian approach, we could decide also to include information coming from observational studies without really including the observational study in the meta-analysis. So we can take in account some a priori information. Then we can also decide not to have one as cutoff to divide a significant result from a not significant result, meaning one in risk ratio or odds ratio, whatever. But for example, we can establish that we will consider our treatment having an efficacy just, for example, if the relative risk is more than 1.2. And this can be decided according a priori observations, for example. And then taking account of the trials we want to include in a meta-analysis, together with a priori information, we can have results of this meta-analysis. Network meta-analyses are becoming quite famous, actually. If we have a study comparing A with B, treatment A with treatment B, and another study comparing treatment B with treatment C, for example, and we can actually perform an indirect comparison between A and C. This is what a network meta-analysis does. It combines trials directly reporting a direct comparison between A and C, but it includes also trials reporting a comparison between A and B and C. Putting everything together, we will have also information about, indirect information about A and C. It's a kind of transitive properties that we can use in this type of studies. It's just important that, for example, if we are comparing treatment A with the placebo and treatment B with the placebo, and we want to get a comparison between A and B, the placebo has to be similar in the two studies, otherwise they don't really have a common comparator. So this is an example of network meta-analysis. For example, all these drugs are directly compared in randomized clinical trials, but there is no trial directly comparing sertraline, that's here, together with duloxetine. You see there is no line connecting these two drugs. But for example, duloxetine is compared with fluoxetine. Fluoxetine is compared with sertraline. So we could use information from this indirect comparison in order to know something about sertraline versus duloxetine. Then let's see, what is an individual patient data meta-analysis? If we have three trials, for example, assessing the role of antiplatelets, on outcomes in myocardial infarction, the investigator can get the databases from these trials and put together the patients coming from all the trials. They will have information about all the patients enrolled in all the trials. This is an individual patient meta-analysis. So it involves the central collection, checking, and analysis of updated individual patient data. It includes all properly randomized trials, published and unpublished. It includes all patients in an intention to treat analysis. But there is an important point. Sometimes it's difficult to share data together with other investigators. If I have my randomized clinical trial, I can think, why should I give you my data? And this means that sometimes it's difficult to perform an individual patient's meta-analysis. And there will be different individual patient meta-analysis, including different trials, even if the topic is the same. But this is wrong, because there will be a selection bias. Because if I'm performing a meta-analysis on a topic, all the studies on that topic have to be included. So this is really important. The benefits of individual patients' meta-analysis are that they allow to carry out time-to-event analysis. It's the only practical way to do subgroup analysis. They are more flexible, they perform a more flexible analysis of outcomes. They ensure quality of randomization and follow-up. They ensure appropriateness of analysis. There is better compliance in providing missing data. And there could be collaboration in further research. So that's all. Thank you very much for your attention. If you have any question.